And I mentioned this to a small group of you a little bit earlier. And that's just kind of the vast quantity of data that we have. And in a minute, I'll drill down and I'll show you some of our actual data points. But for each and every, we respond to about 90,000 emergencies each and every year. And for each and every one of those responses, we have well over 500 data points that we're tracking. And all of that goes into two separate SQL databases. That then we can utilize some of the tools that we have in order to extract information that we want to track, trend, and use them for different tools. One of the things that I want to share with you, which is a little bit different than kind of, I think, the real focus on drilling into data, is the system that we utilize at the medical center.
Just escape.
Let's go back here. We use a system at the medical center known as Marvelous. And what Marvelous is it's actually a tool that uses historical data to predict where it is that the next 911 call is going to happen. And that's, to us, pretty fascinating. It kind of goes against anything that you would normally think of, because I think the true sense of when you think about emergencies is that by their very nature, if they're an emergency, how can they be predictable? But the truth is that emergencies are very predictable. And that's one of the things that we've really tried to be pioneers in, is looking at our historical data in order to anticipate where it is that's going to be needed. And then we redeploy our ambulances based on the data that we have. And it's not just kind of looking at specifically how many calls happen in a certain area and moving things. It's looking at how do things happen temporally. So what does that mean to us when we're looking at time? What does it mean to us in terms of movement of ambulances? And so for us, this system here that you see up here is not ours, but it's the same system known as Marvelous. There's a few places across the country to utilize it. And what it does is it looks at, as I said, the historical data. It looks at every 911 call that's happened over the past 5 years or so. And then it plots it out on a heat map across the city, so that we can see where the emergencies are most likely to occur. But it also does it based on time of day, day of week, and season. And that's really part of the key for us, is it allows us to make real-time adjustments. It updates every 30 seconds. And it allows us to move our ambulances across the city depending on where it is that it's saying that the next emergency is going to occur. And what we found very interesting is that it's beyond kind of the normal things that you would expect, that you're going to have more calls during the day and less calls at night, is that by looking at this, you can really kind of track and trend not only the emergencies, but just human behavior. And that kind of is how you correlate it. So what we use as kind of an example is if you talk about what the fire service does. They put out fires, right? They put out fires in a building. And if a building is wooden and doesn't have sprinklers, it's in the same place day in and day out. It doesn't move. And so when you look at kind of how you're going to deploy fire apparatus, you say, I'm going to put more fire trucks where the wooden buildings without sprinklers are, and I'm going to put less fire trucks where the big steel buildings with sprinklers are located. Because at any time of day, at any time of the day, you're just as likely to have a fire in those wooden buildings as you are at any other time of day, because buildings don't move. What's different is that we're people. And all day long, my job as the EMS director is to keep you healthy, is to keep you safe. Not your home. And you move around all day. And probably like me, you have a habit. You have something that you do every day. You get up at the same time. You go to the same coffee shop before work. You take the same route to work every day. You get there right about the same time. You leave about the same time. Maybe you go to lunch about the same place. And so by thinking through it like that, a lot of this makes sense. Because I want to move my ambulances to where it is that you are at any given moment. And I want to move my ambulances to where it is that for lack of a better word, the people that are not maybe access to the same amount of healthcare, so the people that don't have the same resources. So I'm going to look at things like socioeconomic trends. I'm going to look at things like location. I'm going to look at things like propensity for violence and some of these other things. And so this map here, and this isn't Jersey City as I said, but you'll see this big red dot here, and whatever community this is, that's at that particular moment what this system is predicting that emergency might occur. So if this were Jersey City, that little red dot that you're seeing there, if it was, say, noon on a Wednesday, that might be the financial district, maybe Journal Square. There's a lot of people, a lot of things going on. It's probably not going to be the Jersey City Heights because everybody's at work. So I don't need my ambulances there. So I don't put my ambulances up there. I move them all downtown. I move them to Journal Square. If this were, say, a Thursday or say not a Thursday, maybe a Friday or Saturday night in the middle of the summer, maybe around 11, 12 o'clock at night, the emergencies are most likely to occur. What happens in the summertime when it's warm out and in inner city? Violence spikes. You can see that in the data that you're going to be looking at. Violence happens on Friday and Saturday nights in the summertime when the weather's nice, and in specific areas. So in those times of days, the Greenville section of Jersey City is where we see most of that violence. We're going to put lots of ambulances down in that section. Some of the other things that you'll see as you're drilling down is the socioeconomics of it. So folks, that live downtown that maybe have more resources, more access to healthcare, they don't utilize as many ambulances. So I don't need as many ambulances downtown. Folks in the Greenville section that maybe don't have as much access to healthcare, that don't have the access to primary care and some of these other tools, we need to put more ambulances there. And so when you look at kind of our trend, when you look at our heat map, you'll always see kind of a hover over the Greenville section, and then it'll get darker at different points of day, right? And then you'll see in the other areas of the city, depending on what it is, the time of day, whether it's a weekday, whether it's a work day, and of course the summertime versus the wintertime makes a difference. And so this is an example of kind of how it is that we've utilized the data that we have to truly make a difference in health outcomes. When we implemented this system back in 2006, we had an average response time of about 9 minutes for an ambulance in Jersey City. Well, once we implemented this system, we were able to reduce that response time to just over 6 minutes, so about a third. We reduced our response time by 1/3, just by implementing a system that put the ambulances where the people were, to put the ambulances where the calls were coming in. Because in the past, like many other services, like fire services, some of these other agencies, we put one in the north, one in the south, one in the east, one in the west, geographically. And we realized that that's not truly serving your community because they don't have an equal number of calls, and you have to distribute them where it needs to be. Talking about kind of, what data can do, through some of the work that you're doing as well is, it's great to say that I reduced response times. It's, that looks great. It sounds like a great thing that I can talk about in a PR firm or whatever. But the truth is, the difference is actually made when you have a health outcome. And so in this case, we had an average cardiac arrest survival rate of about 17%, or a resuscitation rate of about 17% before we implemented this system. Once we implemented this system, our cardiac arrest resuscitation rate increased to almost 30%. Right? So twice as many people that were going into cardiac arrest that needed CPR were surviving. Were able to get to the hospital with a pulse. And that's a huge outcome. So actually here in Jersey City, through this and some of the other innovations that we've implemented, the United Rescue Program, which Tom's a part of, and some of the other programs we have an average resuscitation rate here in Jersey City of almost 60%. Means more than 1 out of every 2 patients that go into cardiac arrest have a pulse when they get to the hospital. And almost about a quarter of them survive, a little more than a quarter of them survive to go home fully neurologically intact. So their heart stopped, we got them back in the ambulance, they go through rehab, and they go home to their family. That's pretty much the highest in the country. There's not good, again, we talk about data, there's no good national database for this type of things. But of those agencies that report it, and I would assume that if you have that good of a data, you're going to want to tell people. If of those agencies that report it, we are right on par with the top agencies across the country. We rival Seattle in terms of the top levels of cardiac arrest survival. And so that's something we're very proud of. Oh, I forgot I could look up here. Let me just show you this program here.
We didn't know you knew how to account for us.
So I just made it. So this system here is a system we call First Watch. And I'll drill down into this a little bit and share with you. And basically, this is all of our data. Everything we have out of all of our SQL databases, our patient care reports, our medical records, all of our dispatch data, all lumped into one system that is an analytical tool. And so through this, we can analyze and trend and track everything that goes on in our agency. So what this kind of came out of is, and I don't have the trigger set up right now, but the dashboard set up. But let's do this real quick. Oh, actually, some of them came up. Okay. This is actually not a bad one, but I don't see the one here I was looking for. This is our one of our dashboards. Let me just see if I can go back here. So this system was developed in the post 9/11 world. And one of the things that we realized on 9/11 was, again, there's a lot of data, and all the same things that Stacy was telling you is that there's a lot of data, but everybody works in silos. There's a lot of information that's out there. And from a health standpoint, we need to have a way to really kind of take a look at the data that we have in order to, kind of make everyone safer. And in the post 9/11 world, we had, obviously the typical terrorist attack, whether it's a bomb or something like that. But there was a lot of talk about what they call bioterrorism. And bioterrorism is using disease, injury, illness in order to, wreak terror. And so what we realized is we had to kind of figure out a way, how do we look at this? How do we figure out what's going on in bioterrorism? And what does bioterrorism mean? And what we wanted to do was kind of say, is there a way that we can, if not predict it, readily identify it? Stacy didn't talk a lot about a system that they use in the hospital, and this is not my area of expertise, but it's called the RODS system. I believe it's called RODS, and what that is it's health data. So every day the hospitals report back data, the emergency departments report back data to the health department, to the county health department, saying these are the types of emergencies we're seeing. This is what's going on. But the problem with that is it's the day after, and so by the time they get that data and they identify some sort of an issue, it's already happened. So either if there's some sort of bioterrorism type event, which could be something very simple, it could be sarin gas or whatever gets released in a subway. Well, we're going to know about that pretty quick. But what if they're poisoning the water supply? What if they're doing something else? And this is a slower type of bioterrorist attack where, you're not going to see that until you start to see some trends. And so from the standpoint of the hospital, a day later you can look and maybe you'll see an uptick in respiratory issues. Maybe you'll see an uptick in GI issues or something like that. But we had kind of a benefit in CMS because we deal with emergency data. We deal with data as it happens. And we have all of that information in a database as part of our computer systems. And so the First Watch system was developed by an organization, by a group of EMS professionals who said, let's harness that data that we have and find out a way that we can do alerts and triggers and let people know that there could be some sort of emergency. And so the first, the genesis of the First Watch was, let's pull specific data out of dispatch logs, and then they added medical records, our EMS medical records, to say what would indicate some sort of a bioterrorist attack. So they kind of looked and they said, well, if you all of a sudden, if on any given day in Jersey City you have 5 people that have a seizure, and all of a sudden the next thing you know, in an hour you have 10 people that have had a seizure, maybe there's a problem, right? Because that could be indicative of a nerve agent attack or something like that. And they said, okay, well, not only do we want to look at a city because, it could just be a busy day in the city. Maybe there's more seizures. But what if on any given day, you would expect maybe 1 seizure at any location, but you're not going to expect 3 or 4 seizures at the same address or at an address that's within a block of one another. Maybe that's indicative of some sort of a bioterrorist attack at like a PATH station or at, a school or something like that. And so what this system does is it looks at all of our data, and in this case, as I'm talking now about the bioterrorism, it looks at things like, specifically I know it looks at neurological complaints, so like seizures. It looks at respiratory complaints. It looks at gastrointestinal complaints. It looks at number of people that die that go into cardiac arrest in any given moment. And it builds it, and then what it says is it kind of has a threshold. And so you'll see here, this red line is our threshold. And the green line is over the past 12 hours where we're at on an average. And if that red line ever exceeds that threshold and says, hey, there's too many, or in the back end, it's also looking at specific locations. So it's looking at, is there a specific location? It will then trigger, we call it a trigger alert, and it will send an alert to all of our phones, anybody that's logged into the system. And it will tell us that, hey, there's some sort of a potential biological emergency. Now, there's false positives. So there's times when, this does go off on our phone every so often, and we have to drill down and we look at it and we say, hey, what's the case here? Is it just that it was a busy day? A common one is, you can see here, the CDC death-related. The threshold's 1.5 in a 12-hour period. Okay, so if you have 2, you've triggered the threshold. That doesn't necessarily mean there's a problem. It could just be 2. So this one happens to go off a little more often for us, and we have to drill down. But if you go back...
Exactly.
It's triggered by 2 events?
Yeah.
That-
Actually, I'm sorry. That's the actual events chart. It looks like down here. It's actually
variable, not a continuous. You're going to trigger that all the time. All you need is
right. So it goes off relatively frequently on this one. But what you want to look at, because we know death related is just one second. Death related is more common. You look at the bio combo. So this is aggregating all of the other triggers. So this is the one we're more concerned about. If the bio combo alert goes off, right? So now you're looking at 25, depending on time of day, anywhere from 25 to 30 events. If that one goes off, then we're more concerned because that's looking at a combination of the death-related trigger, it's looking at a combination of the respiratory trigger, the GI trigger, and all the others, and aggregating them and giving us a better picture of what's going on. So if I see my phone go off and say the death-related trigger went off, it's kind of like, okay, I'll take a look, but most likely it's just an anomaly. If I see the biocombo alert go off, then I'm concerned.
nothing that has a threshold of 2 discrete events is going to be useful.
Right. Exactly.
Because,
Mm-hmm.
I mean, assuming the histogram of over time is normally distributed,
Right.
it's just going to be totally
Yep.
spurious every time. Almost certainly.
Exactly. Yep. So that's why it's important for us to utilize that. So the way these work is they build on one another. So you have certain triggers that are maybe smaller, but then there are additional triggers that are built on top of the sub-triggers, if you will. And so it's looking at how many times the alerts or how many times the different things happen and then aggregating it into a larger one. In other cases, there's certain things that we want to know about right away. So
Zoom in a little bit.
zoom in, sure.
Yeah, command plus.
If I can find the plus. That's not working.
One next to the space bar.
Oh, okay.
Yep. There you go.
So, for example, this is our Ebola trigger. Well, thankfully, it's at 0. The moment that hits 1, we get a little bit more concerned. And that one is looking at specific signs and symptoms. It's looking at things, statements about specific countries. It's looking at statements about trips to Africa. This is not necessarily. This is not only looking at data points. This is also looking at free text. So it's looking in narratives. It's looking in comments to see if there's any comment about. And I don't know specifically. I'm not sure exactly what they are. But it's looking for the countries. I don't remember what they were. It's and some of these other things, recent travel, and this will give us a trigger in real time.
Probably travel from Nigeria and a fever.
Exactly. Yeah, it's looking for fever. It's looking for the word Nigeria. It's looking for the word. I can't remember the other countries.
Is this still on? Are you guys still looking for this?
Yep. It continues to monitor.
I think this is a perfect example where you want to have a trigger at 1.
Right, yep.
Because that's where it starts.
Exactly. So in addition to being able to look at things like triggers, what this also does is it allows us to track and trend compliance and track and trend any kind of data that we want to look at. So we talked before about the narcotics. We can look at, let me see here, where's the button? I mean, this is just 4 calls in the last 12 hours, but and everything here is de-identified, so this is not, I'm allowed to show this. So the map is not going to be exact, it intentionally moves the dot. Those are not the actual addresses, it de-identifies them and moves them a couple blocks away, but you can look and see kind of, well, where are they happening? Well, maybe just by looking at this, I can say maybe there was a bad batch of heroin in that area, just in the last 12 hours. I mean, they're all right at the exact same place. So, these kind of things can give you some good information.
Do you use this with the heat map to station ambulances? Like if you start seeing something like this, are you going to move ambulances to that area?
So not specifically because, the heroin overdoses are not necessarily, that's not the one area. We have a whole broad amount of things, but we use that heat map that I showed you when we started in order to move the ambulances. And those are 2 separate systems. So First Watch is one system. They're working off the same database, but First Watch is one system and Marvelous is a separate system. This is real time as it happens, giving us data. Marvelous is, I would say real time because it's looking at historical data, but it's updating in real time based on historical data to tell us where it is we need to go.
Right.
This is an old dashboard, but I can show you. So this is an example of kind of looking at where we're at in terms of compliance, where we're at in terms of our key performance indicators. And so you can see here what we're looking at is, in the city of Jersey City, we want to make sure that we get to an ambulance to you in 7 minutes and 59 seconds. That's what our standard is in Jersey City. Thankfully, it's much lower than that. Our average response time is about 4 minutes and 30 seconds. But with anything, as you guys know with data, averages mean that half of them are less and half of them are more. And so you want to look at, how often does it happen that things are more? Because like anything else, when you respond to 90,000 emergencies, there's going to be fallouts. There's going to be times when it does take an ambulance longer to get there. And thankfully, in this case, we're 95% of the time we're there in 7 minutes and 59 seconds. And that's well within our contractual standard. So we can use this, and this data is available to all of our supervisors, all of our tour chiefs, all of our dispatch center, and they're looking at it. It's up on the screen to make sure that we're compliant, to make sure that if they need to make any adjustments, whether they're going to add more ambulances, whether they're going to try to figure out is the ER backed up, is there a reason why we're starting to drop off, is there traffic issues or whatever. Or in cases, maybe if this is at 100% all the time, that's good, but we need to look at the economics of it and say, how are we at, and are we staffing appropriately? So this gives you real time. We can look at the past 12 hours. We can look at month to date. We can look at year to date. We can look at the past year, just by going up here and pulling it down. But we can also drill into these. I'll pick one of these.
Rob, before you go, can I ask you a quick question about your previous, not slide, but page? You mentioned historical data, and you compare it to up to the moment.
You talking about the first system I showed?
Yeah, one before the little clocks, right?
Okay.
Well, anyway, my question is, the historical data, and I'm just learning these terms, by the way, because I'm working on BCAC. So, it's called like a reference period. How many months do you use, or how many years do you use for the historical data that you compare?
I'm not 100. That's a good question. The actual total data that we use it's either 2 or 5 years. I think it might be down. We reduced it to 2 just because when you start going back too far in a city that's growing like this, we used to have 5 years worth of data, and I think we've reduced it to 2. You still want a big enough subset because it's based on time of year, day of week, and season. And so you have to have a couple years in order to be able to predict what's going to happen in any given season. But you don't want to go so far back that you're getting data from before roads were created and before certain things existed.
So the standard trick is to use a trailing time period from your current date, and then
Right.
you usually weight it in some capacity closer to present time. So an exponential weighting is a common thing. So the day prior to this day is much heavier weighted in your model than one
Right.
2 years ago.
2 years ago.
Right. And that may be that may be what they do in the back end. I'm not sure. And then it's based on I think it's a 3-month period. So every day as you're moving on, the clock it's looking at it and it's moving like this as the day goes by. So it's saying in the season. So if it's what is today? Saturday, March 19th. It's looking at in the area of March. So 1 month before or a month and a half leading up, a month and a half afterwards. So from middle of January to May, it's looking at it and saying, traditionally, February, March, April, what happens on a Saturday it's about noon, between 11 and 1. It's a 2-hour period.
So that's considered like the period of interest, the 3-month window?
3-month window, 2-hour, it's a 3-month season window, and then it's a 2-hour window for the day, and it's a specific day of the week.
Okay. Does this company provide the specification of how they're analyzing it to you guys? Is that transparent to you?
Mm-hmm. You mean this?
That
Yeah.
specification, this is how we do it.
Yes.
Okay. Would that be shareable?
Yeah, sure, absolutely. I mean, I'm not that great at understanding the full technical back end of it.
But just a specification of a shareable, it'll give us a great insight into how you guys are doing it.
Mhm.
And if we were to do any of our open source projects, that'll be a good template for us because you're doing it in real life and you've been
Right.
successful using that data effectively. So
Right.
that's a great template for anyone doing something like this to kind of base their stuff off.
Right. Yeah. So just kind of showing you this. This is this is kind of some of the things it shows us based on hour of day, how many emergencies we have. In this case, the green are all the ones that we got in 7 minutes and 59 seconds. You know, the couple little red ones are the ones that fell out of our, where we fell out of compliance. I'm not a good with a Mac.
Who
How do I
knows
do this?
the zip codes around here really well, like where they are?
07302
How do I do this? Go down.
07310.
I can
So,
tell you,
like-
what do you need to know about the zip codes?
So here's an interesting fact. I just did bar charts across all zip codes for all reported cases. So 7305 is by far the worst.
Okay,
But-
That's the,
So it's
the,
Greenville.
yeah.
Yeah, but 7306 is worse for alcohol intoxication.
That's
That's
Journal
my
Square.
area.
That's the Heights.
That's where I live.
Yeah. Journal Square.
Journal Square, yeah.
That's
Heights.
that's a big outlier here.
That's where they're gonna be building up, to try to change that.
Yeah, so I, and all that makes sense to those of us there, but you know there is a large homeless population in Journal Square, right by the PATH train, and obviously the homeless population has alcohol issues that we're trying to deal from a public health standpoint. It's also the last stop of the PATH, so anybody that's coming back from New York City that passes out on the train stops in Journal Square, and then we pick them up there. Yes, please. Yep.
Okay.
Interesting.
So 07310, I don't know where that
It's
is.
Newport.
Okay, yeah, so that's by far the lowest on everything. As you would.
Yeah, it's also
expect.
that's the wealthiest zip code.
Yeah, but it's fairly, it looks like it's fairly consistent across regions, so I'll regress them against each other to see what the outliers are. It'll be interesting.
What does 07307 look like?
The height.
Yeah,
The heights,
not that busy.
okay, so the heights
Depends on where
is
you are.
like 1/3 of what 05 is most of the time. Not like almost all of them. Yeah, there's
The Heights is our lowest volume by far.
That's where I live, so thank you.
Now, before when we were talking, you were talking of getting down to 0.2 of a mile, 1/10 of a mile.
Yeah, hopefully by the time you guys code again, we'll give you stuff that's down to 1/5 of a mile
1/5 of a mile.
Down there.
So,
rather than zip code.
So, said out,
so
that's
that will be,
post,
so that
that's
will be
post
much
summer
more
now.
granular data.
Yeah.
You know, for example,
This is pretty cool
Greenville.
for today, though. So
Yeah.
You know, for example, Greenville includes what everybody thinks is Greenville and Port Liberty.
Right. So you'll be able to track Port Liberté separately.
Plus, Greenville's strange because Greenville's also Society Hill
Yes.
and Country Village, and then Baghdad. You know,
Yeah.
it's all.
Mhm.
Did you say Baghdad?
He did.
Oh, the hill?
You know, like.
Baghdad the hill?
Yeah.
So we can actually drill this down a little bit. If I click here and I look at the events looking, I can look at every single event. So you can see it goes in reverse, but we can look right now what's happening. Let's reverse this.
this ratio across zip code is super consistent.
So this is in real time. This is telling us right now as of well, my clock says this happens in a minute from now, so I guess my clock's off. But we just had a
That's PM. That was yesterday.
oh was it?
3:18.
Oh.
We're at 3:19.
Yeah.
So that was midnight last time.
Well, I'll show you this one anyway. So you can see we drill right in. Again, this is all de-identified, so you just find you're looking at this. We took all the data out.
Yeah.
You see it says Jersey EMS everywhere, but it tells us, what time. So the ambulance was assigned at 11:53 p.m. The ambulance arrived at 11:55 p.m. The patient didn't want to go to the hospital. They refused treatment. Gives me even things is down as so this call was at it's not, you don't know that, but it will tell me where the ambulance was at the time they were assigned.
Yeah.
So for anybody that unnamed street / Gilchrist Street is Jersey City Medical Center. I'll tell you we talk about kind of the limitations of data. One of the biggest struggles for us is that they build new streets here every day. So it becomes very difficult for us to not only have good data, because if the street doesn't exist, the dispatchers have to freeform it, in which case it doesn't have any kind of geo-coordinates, because everything here is geocoded. So if they just type in a street name, it's not geocoded. And if the street's not in the database, then it means that it's not in the GPS system either. So when a new street comes up, we have to hire professional mappers, professional GIS folks to add streets to our CAD system, which it gets very expensive. Yes.
Well, Division of Zoning and should be able to help you with that. I would think at no cost, the zoning and building department, you know? If you could get into their data,
Yeah.
maybe it'll save you some money.
Yep.
you know?
Yeah, absolutely. But so for us, when we get this, and then so say this is a huge problem downtown. A new street will be created, and we type it in, and then you don't know where that is, which can create problems for responses and everything else. Because if the dispatcher is just typing in freeform, it's not geocoded. Now we don't know where it is. Now the GPS isn't directing them to it, and now the ambulance has to go to. I'm trying to think of one of the newest streets around, but one of the streets in Liberty Harbor, even here, Morris Boulevard
18 Park Avenue.
or Park Avenue, and everyone's saying, "Well, where is that?" And now the ambulance has to delay and spend time saying, "I don't know where I'm going." And for the dispatchers, when you have ambulances all over the city, now the dispatcher is saying, "Well, which one do I pick? Because I don't know where that street is," and they have to do follow-ups and try to locate them. Now, thankfully, that doesn't happen very often.
So you
But
have to keep updated what's really happening
Right.
at the ground level.
Why on the ambulances, when they finally get there, that location then geocoded as new location, here's the street?
I think it's just the limitations of the mapping, because you have to have a GIS specialist that's going to give you the information. Mhm.
When you say the time arrived at the scene,
Mhm.
does that mean the actual address or the time that they actually got to the patient?
The address. Yeah, that's a limitation in data and EMS. You will not find any EMS system across the country that has good, accurate data on when they got to the patient. We probably should come up with, now that you have the technology, a handheld thing where you can hit the button when you're walking, but like anything else, when you're dealing with public safety and big data, sometimes we're a little bit slower than maybe we want to be.
Question, what do we need to do to help us get the data for June 4th, our next hackathon? Should we write a letter?
I mean, you can send us a letter. It's likely we'll be able to get it for you. I can't anticipate. And certainly anything we share with the city, which, again, we'll be sharing that data with the city. The moment we release it to the city, it's public record. So I can just save the step of giving you this. So what you're seeing now is all the data we share with the city. So at least that particular, it's all the raw data we share with the city. So, that was easy for me to put on to give to you.
View it. But we would partner with the city, though, also. Like we did the National Day of Civic Hacking last year.
Mhm.
We partnered with them. So.
Okay, yeah, we can try to sort that out.
So it's a matter of just resources on your side, right?
Mm-hmm.
How much resources you can
The
put
system
on that
says
Right.
project.
It's like $30 to take an open request, but I think they would probably waive the $30 to this one.
Yeah, I mean, if it's our data, we can. If we've already provided the city, we're not going to make you Oprah it. We'll just give it to you. So,
I think in this case, nothing, right? You basically,
right.
you guys are doing this as fast as you could.
Right. And if you have any specific, what I can tell you this is, as you're drilling the data, if there's something you say, wow, I wish I had this data point, I wish I knew this. If you can just kind of provide us with a list of data points you want, then I can certainly review it with our legal team and make sure and see if we can release it.
We'll include that in the letter.
Mhm.
Is there any way we can have a session where we can see what you guys have?
Mhm.
And then we can say we want A, B, and L. And then you can say we can give you A and B, but not L, because L we cannot legally give it to you. But right now, we don't really know what you guys have.
Right.
So our
Yeah.
response would be give us as much as you can
Yeah.
legally can.
Yep.
And then,
Well, yeah,
you
and like I
use
said,
what
it's a
we
lot
can.
of data. And the
Yes.
other thing with us, and you guys know this better than I do because I'm not that tech savvy with that, but some of these are, some of the data is like pick lists instead of actual items. So that's an issue we face sometimes where if you can select more than one item, the SQL database becomes then whatever multidimensional. I don't really understand, but I can't just dump it in an Excel sheet because if one column is going to have 6 answers, I have to pick which one of the 6 I'm going to put in that column.
Absolutely. You can give us 20 Excel sheets. I mean, really, because when you're extracting data from your tables, from your SQL database, you could give us 20, 50 Excel sheets, and then it'll be a huge task, but it's for us to then try to make sense of that data by looking at common fields. So if one has, say if you have a runtime, whatever that run code, right, which is basically a dispatch, and then it has one table in one Excel sheet, and we have the same run code in another Excel sheet, then we know that those two things are tied
Right,
together.
yep.
So we will figure that out.
Mhm.
So that's why a session, if you can legally do it, like have us see the data
Mhm.
that we are not going to take out,
Right.
but just see it visually, then we can say what we are
Yeah.
interested in.
I mean, I can share with you the fields. I mean, this, like I said, this is all de-identified, so you can see they pulled all that stuff out. But these are all the data fields that we have. This is all the data fields we have for on the dispatch side.
Yeah, showing us what the column names are.
Yes.
Yeah, that's pretty cool. And if you column names and then the type of data that's in that column. So like what be it numeric or date time or something like that. Because then we can better advise you at that point as to what would be useful. I'm sure some of this doesn't matter. Less approvals you have to get before you release it. It kind of goes against my intuition in the sense that I'm all for just getting everything and then filtering. Obviously, in this case, it's not necessarily an option because
Right.
you have the HIPAA rules.
Let me pull this one up here.
So we're still getting quite a bit, so.
Yeah. I mean, I already found some fun stuff from what you gave us already.
So this is all of our calls. This one here in the past 12 hours, so you can see. So I showed you kind of looking at the drilling into there, but you can also you know, this is all the type of stuff that's looking at. These are all we have all these data points for specific things we can talk about. You know, consciousness, unconsciousness. What even what position were they laying in the stretcher? You know, were they in a stretcher? Why did they decide they wanted to go to that hospital? What hospital did they go to?
See, for example, that is probably a good data point for us to have. That is not personally identified. How many people went to what hospital?
Mhm.
Let me ask you something. As a resident, a parent, right, of a child who plays football, if I wanted to see how many concussions there are
Right.
reported for student athletes, is that something that I can get?
Well, it's harder to do because we don't. It's not that specific. So I can tell you how many head injuries we have, but I can't necessarily track it back to football or not football, or whether it's a concussion or not concussion.
It doesn't have age range.
I can give you age range and head injuries, but I
Yeah.
couldn't necessarily give you, you know, and if that's something you wanted to partner with us on, you know, if that's a passion of yours looking at head injuries in teens, we can, you know, either give you the data or we can work with First Watch and drill down and take a look at it.
So
Do you have a
that's probably
narrative?
not something you collect, but you
Any
might
kind of
be able to
narrative
so
that's
you
in
can
there?
say, look,
Yes.
this is the
And
address of the
from
school,
that,
this is the time of
probably,
day it's
if you
reported,
can
head
release a
injuries.
narrative,
Right,
So
football
then
or-
we can,
like,
then we can look for
sports,
terms
okay,
like
we know the
concussions,
effect of
football,
between
and
3
things
and
like
5
that.
p.m. These are
We don't have a lot of sports injuries, so you know, as you were saying before, it all depends on, you gotta have enough to track and trend. There has to be enough of them. So I don't know. You'd want to look and see how many, because if there's only one or two, or 3 a year, it's not going to give you good data.
And schools probably have their own workflow around their athletes
Yeah.
and stuff, right?
head injuries. Like here for one school, that's not a lot of data.
So you giving us access to this tonight?
What's that?
You
No.
giving us access?
Nope.
Just give us a password.
Created CodeJC, I was like, oh wow.
But you look at everything we can do
I think just
maps.
for us to see out here, here to make sure.
So that's mapping out all the calls that have happened in the last 12 hours based on type of call.
Yeah, then
Any in this building?
Any in this building? Probably not, but very unlikely. But we can look at destinations, how many people went to what hospital, and with what complaints. And then we can also do analysis. So this is all 12 hours I've been showing you, but I can do all of those things based on any time period over the last 10 years at this point. There's about 10 years worth of data that's in here. And we look at all sorts of things. So that we look at gunshot wounds. You can look at stabbings and assaults, heart attack victims. Yeah.
So what's the longer term plan for open data here? Like I'm familiar with like kind of like New York City and a lot of hospitals, and they're trying to really standardize how the data is stored, but also how it's presented to the public. Like a lot of it's through kind of like web APIs. I don't know if you're familiar with that. And that way, like you were saying, there's like a million combinations and permutations of this data, and so it's easier to just kind of basically make access to your database online so people can run this and that and match it together, rather than me make a request and then you like generate an Excel file and send it out, and it's very manual.
I'm not aware really. I mean, there's a lot of talk in hospitals, in healthcare about data. Open data, I have not heard many conversations, just because it is such sensitive information, because we're dealing with people's health. And one of the things that we also struggle with is, as I said, the HIPAA talks about, or maybe I said it in the other room, but HIPAA looks at what's identifiable, and it doesn't specify what does that mean. So, for example, you may think that an address, we get on the air, we say we're going to 123 Main Street. You hear it on the dispatch. If you got a scanner, that's all legal. But and it's a special exemption that we have for HIPAA that allows us to respond to emergencies. But when you think about it, someone's address can identify who they are. If I'm sending you to my place, 100 Shearwater Court, apartment 21, and that's in a database I give you, I'm the only person that lives there. So if you're going to 100 Shearwater Court, apartment 21 for someone who an overdose, well, now you know that maybe I have a drug problem. Well, now I've definitely violated HIPAA. So I have to be careful, because I can't just give an address out, because that might identify that somebody has a drug problem, or even if they just care about knowing their health. I mean, somebody might care. They don't want you to know they have cancer. They don't want you to know that they have a heart problem.
I don't think the recommendation is that you give like unmitigated access. The idea would be is that you would have a view onto the data that is compliant with HIPAA.
Right. So what I'm getting at here is not just about that. It's also that might not be, you can probably understand as I described it to you, but the difficulty sometimes with doing open data with health data is you never know how it's going to cross.
Sure.
That all of a sudden you think that this is completely de-identified, but somehow you're able to drill down into the data and you figure something out. And whether we intended to or not, we've now broken federal law. So it's a lot easier for us. What we usually do with our data is we look at it first, and then we release it to make sure, okay, we're going to look at this and say, well, is there anything in here? So open data, we could probably, what I just gave you, there's no reason why we couldn't do that. And I don't just think hospitals aren't talking about it. But the more data points I give you, the more we get hesitant to look at it and say, okay, we might be willing to share this and kind of work on it, but I'm not just going to put it on a website because somebody might be able to figure something out. So the right answer, I don't know. I mean,
it's a monumental task for sure for you. I think we all appreciate that. And to be frank, I think you'll reach a certain momentum point where there'll be so much open data that any data you release will be cross-referenceable.
Right.
Eventually, you give me enough time and enough data, I'm definitely going to figure out like where that accident was.
Right.
Because like New York Times might start releasing like a thing, and then I'm like, oh well, there was only one accident of this sort of this time of day, and I cross-reference it with the news, and boom, I know where it is.
Right. Yep.
I mean,
now a lot of that stuff. I mean,
the law has to be within a reasonable expectation, right? I guess that's my point.
Yeah, I mean we're pretty open with a lot of stuff that's already public. So talking about where was a car accident, and again, I don't know what the HIPAA, the Department of Health or whoever the regulators are going to say whether or not I can do that. But for us, we're pretty open about, well, there was a car accident here, and we don't. Somebody might say that's health information, but we say it's probably not, and we'll tell you. But again, there's without clear guidance telling us what is and what is not health data. It's one thing if I kind of share something with you here, we kind of work on something together. It's a whole other thing to kind of put it on a website and say, hey, anybody that wants to come take a shot at us, feel free. Here's all the data we have. But I think we're getting there, and I think you will see more data. And I think, like anything else, you're dealing with kind of something that's new, something that you deal with innovation. We're very proud of all this data we have. I can assure you that there's probably no other EMS agency in the state that has this kind of data and has this access to this kind of data. They can do this kind of drilling and finding. And if you ask them for data, they'd probably look at you and say, I have no idea how to even get it out of my system.
Do you feel that you have a higher requirement for this new technology because due to your incidence rate per your population or lack of infrastructure or any other sort of requirement?
Well, the reason why we have data, is obviously, for patient care, we want to improve outcomes. It's also about economics. Actually, I'd be happy to kind of give you a little bit of a, I could pull up a short interview here, but there's a gentleman by the name of Jack Stout, and he's very famous in the EMS industry, and he developed not the Marvelous system itself, but the idea of moving ambulances around all day long based on demand and staffing and all of those types of things. And his background's not in EMS. His background's in economics. And he was a professor of economics and then got involved somehow with an EMS project at his university. And he became the founder of what we call system status management, which is using data in order to find it. Because not only do you improve outcomes, but you also improve economics. Because I don't need as many ambulances. If I could, I would save a lot of lives if I put 500 ambulances and put them on every street corner. But that's not practical. I can't afford that. No city can afford that. So the data gives me the ability to be cost effective. And then the other piece for us is, as a contractor for the city, I have certain data reporting requirements. And so that's an important part for me. I want to make sure that I have that information available. And I have a compliance piece to it too. So the more access I have to the data, the more I can see something happening before it happens. Because the last thing I want to do is at the end of the month run my report and find out I wasn't compliant. I want to know as soon as it's happening that, I have a problem. I need to add more ambulances because, I can fix it if I have a day. But if on the 31st I run my report and it says I was only 70% compliant in a contract I have to be compliant 95% of the time, I'm in trouble.
Do you do any allocation based on the perceived cost of the incident? So, like, an example would be, like, you might know, like, lots of people, like, stub their toes, like, over here, right? Like, so by raw number, it might make sense. There's 500 stub toes on column A, right? So I put 10 ambulances there. But there's one murder over here, right? Mm-hmm. So how would you allocate your one ambulance then?
Well, we allocate based on severity. We actually, all of our deployment model, so everywhere we deploy ambulances is 100% based on life-threatening emergencies. So we actually, that Marvelous system I showed you does not look at low acuity calls. So it's only heat mapping this most serious emergencies.
So you wouldn't have a situation like, imagine where, like, now it's not 1,000 stub toes, it's 1,000,000 stub toes, right? Versus one murder. So maybe you do want to put all your ambulances over there.
Yeah, so and that's a good point. That's an area we don't look at, and that is you bring up a vulnerability because we don't look geographically or whatever at the lower priority emergencies. We move them. We look at them for the highest priority. So we move the ambulances based on where the chest pains are most likely to occur, where the cardiac arrests are most likely to occur, and part of that is I spoke before. We talked about response times and things like that. Response times make a difference in the most serious of emergencies. They make a difference if you're having a heart attack. They make a difference if you're having a stroke. They make a difference if you're cardiac arrest. Maybe 3 or 4 other, if you're bleeding out or something like that. But outside of those, if you're having, if you got a stub toe, if it takes me 10 minutes to get there or it takes me an hour to get there, nothing's going to change. And everyone has an expectation that an ambulance is going to be there in 5 minutes. And one of the education pieces nationally we're working on is you're not going to get an ambulance in 5 minutes if you call for a stub toe or even a sprained ankle or even a broken ankle. Because we also have to weigh the danger to the public of sending an ambulance, lights and sirens from across the city to try to get there in 5 minutes when you have a broken ankle. Well, how many pedestrians did I hit? How many cars did I hit trying to get there too fast? And actually the trend nationally, and New Jersey is a little behind, is we don't use lights and sirens anymore, except for about 3 or 4 emergencies. Across the nation, if you call and say, I fell and I have a broken leg, the ambulance is going to drive in traffic to come get you. They're not going to use their lights and sirens because you're putting more people in danger racing through the streets. And what they found is that in most areas, the decrease in response times by using lights and sirens is so minimal. It adds a minute, it adds 2 minutes, maybe it adds 5 minutes, versus I'm going to go through red lights and traffic and drive on the wrong way of the street. What's the cost benefit for us of doing that? And so that's kind of the piece of looking at, you want to get to the most serious emergencies first. You're going to use that data to plot things out, and you're just going to have to wait. So if you got 1,000,000 stub toes, take a number. Your number 999,000. We'll get to you when we get there.
So is the most serious thing like chest pain? Like how would you categorize?
The most serious, our highest level of call, we do them alpha through echo, and an echo level call is someone who's not breathing.
Okay.
Then a delta level call is someone who has some sort of instability, so severe chest pain, severe difficulty breathing, and we have a series of questions that our dispatchers asked. It's a nationally vetted model that they've done a lot of things on it. It's standard across the nation for accredited dispatch centers, of which we're very proud to be the only one in northern New Jersey. And they ask very specific questions, and then based on your answers. So if you call 911, a lot of people get very angry. We screen these calls and they'll say, "Why are you asking me all these questions? Just send me the ambulance." The ambulance they're not the same person. I've even said, "Why don't you get in the ambulance and come here?" Well, no, I'm not the one that gets in the ambulance. I send an ambulance. I'm the guy on the phone. But so as soon as they answer the phone, that person's asking questions. As they're entering the data, there's someone else sitting somewhere else that's talking to the ambulance and sending the ambulance to the call. So the moment we pick up the phone, as soon as we get a confirmation on address and telephone number, the ambulance is off. Because the very first thing we ask when you call is, I know a little off topic here, the very first thing we ask is, what's your phone number? And we won't let you go anywhere past until you give us your phone number, because we want to be able to call you back if the line gets disconnected. The second thing we want to know is, where are you? Because God forbid something happens from there, we can now get the ambulance to you. And then as soon as we get those 2 data points, the ambulance is already going. We don't even know what's wrong. The ambulance is already driving in that direction. And then we start asking you questions to identify what is the acuity. And what level. So we call it a stack. So we put you into the stack at the middle level, kind of a middle priority, while we wait to find out, and then we either upgrade you based on we found out that you're not breathing, or we downgrade you based on we found out you had a stubbed toe.
Is distance from the ambulance in a part of that factor in the stack? So imagine I have 2 pretty serious cases, right? Like one person's not breathing, the other one has severe chest pains, but the ambulance is sitting on top of the person with severe chest pains. So it's right around the corner.
Say that again? I'm sorry.
So imagine you have 2 very serious cases,
right.
Like your 2 top. I
Yep.
don't know what they are. I'm saying chest pains and not breathing, right?
Uh-huh.
But the ambulance is sitting next to the person with severe chest pains.
Right.
So do you route the ambulance over to the guy even if it's across the city? Maybe it's going to take him 15 minutes.
That's where humans come in. That's why we can't automate everything. So we don't have a computer that does it. So there's no policy on it. It's the dispatcher, the dispatch supervisor. They're looking at it. There's so many factors involved. If somebody's not breathing, you got to get somebody there right away. And severe chest pain might not be severe chest pain. It might be that they just have a low pain tolerance.
Sure.
So you have to look at it and say, okay, well, this one's right on top of this, and there's, it's not for. I mean, I don't want you guys to think that we don't have ambulances available. That doesn't happen. But in a theoretical world, you're on top of the chest. Say there's only one ambulance available, and they're on top of the chest pain, and then the not breathing's across the way. Well, maybe there's an ambulance that's in the ER, or somebody's in the bathroom, and they're going to be free, and the dispatcher knows in 2 minutes that ambulance is going to be free, and it's closer to that one. Well, okay, I'm going to factor that whole response time in, because the full response time that we use is time of pick up the telephone to time of ambulance arrival. And so if I know that the delay from phone to the ambulance going is going to be a portion of that, but they're close, I might say, well, rather than send this one 9 minutes from here, this one might not be ready for 3 minutes, but they only have a 3-minute response time from that point. So the total is only 6 minutes. I'm going to wait for that one to become available rather than to send the one that's 9 minutes away.
And there's certain things like not breathing. Like after a certain time distance, it doesn't matter anymore. The ambulance might as well not exist, right?
Yeah, that's true. I mean, that's part of the goal is much like fire prevention is injury and illness prevention in EMS. And as you guys, I mean, maybe I'm the only one that notices these things, but as you were walking in the door here, you saw the sign that said this is where the AED is. The more stuff we put out there, the more it makes it, it helps your lives, it makes our lives easier, because if we can get somebody that starts CPR that puts the defibrillator on, then in that case, no. If the ambulance takes 10 minutes, everything's, not fine, but you're in a much better place because they have the care they need. It's much more concerning if the ambulance is 10 minutes away and everyone's standing there because they don't know how to do anything.
Are the dispatchers looking at like a real-time map of like where the actual ambulances are?
Mm-hmm. Yep.
Okay, so it's like GPS. So
Yep.
You can see it go just. Okay.
Yep, I get it on my iPhone too. I can at any time pull it up.
Wow, this is very awesome.
Very
nice.
Thank you.
Really.
Very educational.
Yes. We needed this.
So, yeah, I kind of question.
Yeah, I know, right?
Can we let him go now?
Well, yeah, I don't want to start hacking. feel free to not listen out. But it sounds like you said a couple times you're a lot better than most other EMS services, and you said a couple times that this is something that you're like doubling your response rate with and saving a lot of people.
Mm-hmm.
So, I mean, are we like, what's the rollout plan? Or, you have an evangelist who goes around to other people and tells
We
them how
do.
great you are?
We try to. It's catching on. When we implemented these systems back in 2006, the four closest systems, because we used to do this presentation, we had to correct it. We would get up and we would tell people about our great system, and we would say that if you want to find another system that has this technology, you have to go as far west as Lexington, Kentucky, as far north as Toronto, as far south as Richmond, Virginia, or as far east as London. We can't say that anymore. So it's starting to catch on. There's more and more agencies. We're not the only one in New Jersey even that uses this type of technology. But it's been a hard battle. There's a lot of tradition, like in anything. I mean, I think Stacy talked about city government and kind of the things move very slowly. There's a lot of bureaucracy. Well, that's true. Police, fire, EMS. We might be a private company, but it's still rooted in tradition. And sometimes it can be hard to break people of their habits. And get them to be willing to look at things. The other thing is that this is, the more efficient that you make things, it changes the culture, it changes the dynamic, it changes the way that people operate. So beyond, you can't just take data and come up with a plan and say it's going to work without looking at what the impact is going to be on people and what the impact is going to be on the ancillary things. And so for us, in 2006, we implemented the system. It was probably 2009 to 2010 before our staff bought into it and said, okay, this works. Before then, it was you're throwing us a bunch of garble, and this is just your way of looking good, but it actually doesn't save lives, and it doesn't matter, and we want to go back to the way we used to do it. We liked, being free to go wherever we want. We don't like the fact that we need to be close to the emergencies. You're changing a culture, and you're trying to convince people that the data works. And so I think you guys as data people probably know that sometimes people don't believe you, don't believe that data can make a difference. And so that's kind of, it's getting people to start to believe in data and believe that this actually makes a difference.
Two
Last
comments.
I was gonna say,
Go ahead.
I can't see you, that's why. Last question, second to the last. What can we do, Code4JC, to help you in any way? Or is there anything? I know you're a private company, but is there anything as a volunteer organization with data experts, that we can help?
I mean, I'm looking forward to seeing what kind of stuff you guys find. I mean, you bring up a lot of good points. I mean, even things as simple as, I don't remember the last time we looked geographically at where all of our lower priority calls are. So that's something I'm going to do now. And telling us, what was it? You brought up again. You were working on this data. So there's a high intoxication rate in 07306, or I forget what the first comment you made was, but we look at things very often. We have access to data, but the Ebola trigger came up once Ebola came out. The measles trigger came out once everybody was getting the measles. The overdose trigger came out when the state police came to us and said we want to see what's going on. So a lot of it is based on circumstance of looking at, we have an emergency, we have an issue, we have something we want to find, so now let's drill into the data. And we can historically look, because all the triggers are good to look back. But if you guys can identify for us maybe some issues we're not seeing.
Here's an interesting one I just noticed, maybe this one, interesting. So, out of line for some reason, there's a massive spike in asthma and respiratory calls in 05 and 04. So it's 07305 and 07304.
Mm-hmm.
Like, it's way out of line. I have no idea why.
Mm-hmm.
Do you have any intuition?
My intuition would be asthma tends to spike in areas with the lower socioeconomic areas where they don't have access to primary care, they don't have access to good prenatal care and all those things, and those are the areas where we see those types of issues. So there's not as much access to healthcare down there.
Yeah, it's interesting because like they're in line more, like they're higher in almost every category, those two areas, but this one is like
2-3x.
Yeah,
it's like 3x where it's expected to be.
Yeah,
Liberty State Park and the pollen or something like that.
it's probably more likely the if I were to guess, and again, it's where you have to look, but I would guess if you look at the living conditions in some of those areas, you see, a lot of mold in homes. You see, asbestos or whatever.
Poor air quality.
Yeah, poor air quality.
And pollution.
Yeah. But a lot of it is inside. So I know you guys have somewhere to be, but I'll just give you the 2-second snippet. One of the new things we're doing in EMS, and one of the things the hospital is doing, is looking at having a more of a preventative role. And what the way we get paid now is changing. We no longer get paid based on the number of patients that we see in the hospital. We get paid based on, or we're going to get paid no longer about how many times you come in. So if you come in once, it used to be they'd write me a check, and if you came in 2 days later, they'd give me another check, and if you came in 2 days later, they'd give me another check. And so we had a economic benefit, not of keeping people sick, but keeping the hospital full, and that's how we got paid. And one of the things that I'm it's stressful for us because it's a whole way of doing things differently. But then I'm very happy of the outcome of the Affordable Care Act is they're saying, well, that's silly. Are you actually caring for them? Why are they coming back to the hospital 2 days later? Are you giving them the appropriate care? And so we don't get paid if you come back to the hospital now. You come once, they write us your check, and that's it. You don't get any more money. And we're responsible to keep you healthy. And now the transition is not only will we not get paid for when you come back, but now they're going to start going to, we're just going to pay you for lives that live in your catchment area. So you'll have a medical home, and we'll get a check, for your health, whether we keep you healthy or we don't keep you healthy. And so some of the things we look at are things like asthma and some of these other things. And EMS has a great role because we're actually in people's homes. And so some of the outreach that we're already doing in EMS is specifically asthma outreach and looking at, what is the quality of your home? Is it clean? Is it, are there hazards? Is there issues that need to be dealt with air quality or whatever else?
In a situation like that, do you then, does your department then call, let's say, the Department of Health and make them aware of the conditions?
That's part of the area we haven't figured out yet because again, HIPAA, we can't call unless it's until somebody passes a law authorizing me to release your health records to them over that. I can't give that information to the health department because they're not your health provider. I can share it with our folks, and so you see this meshing of hospitals and healthcare almost stepping into a public health role and kind of blending the roles a lot of what the cities do. Because now we have a whole department in the hospital that deals with, home visits and checking people. And while we don't have any enforcement power, we'll coach people on, hey, we were in your house and we realized that you've got whatever air quality issues you have, mold or whatever. Okay, well, here are the resources we can give you. We can't report you, but we will then take the person under our wing and we'll put them into a program through the hospital because they're covered as healthcare providers. And even though we're not really providing health functions, we are because we're providing, it's not healthcare in the sense that you might think of, but it's healthcare in the sense of we want to get you to be healthy.
Okay, probably a last one, but is Marvelous the only company which does this, or there are other companies who do that?
No, it used to be the only company that does this. There are a couple other companies. I believe there are different, there's some outstanding legal disagreements on proprietary software and things, but I believe there are 3 now that do it.
Okay. Do you think there will be appetite among smaller hospitals who don't have the budget to bring in something as sophisticated or Marvelous or their competitors for some free solution by a volunteer organization? As a first step, it may not be as sophisticated, less sophisticated, but do you think there's an appetite for that?
Yeah. I mean, if you can plot out we know where our calls are, but I can guarantee you there are many EMS agencies that don't know where the calls happen other than anecdotally. Hey, I know we always go to this area of town, but I doubt there's very few places that could tell you, that could plot out on a map where all their calls happen. I mean, I know I come from another agency, this isn't the first place I started, and we talked about it. We're like, oh man, I sure wish we could put on a map where everything happened, but the data wasn't available for us.
Okay. How many EMS agencies are there in New Jersey?
I don't know what...
approximately 100?
Oh no, there's probably 300 or 400.
400 in New Jersey alone?
Yeah.
Okay, and of these 400, I mean, just a guess of how many have anything like you guys? Any of...
To this sophistication, there's none.
Like any kind of data-driven response, or they're all doing it by the seat of their pants?
No, there's some. I'd say probably most of your most of your bigger hospitals that have EMS agencies have some sort of data. They have access to it. I mean, they also have the resources of a corporation to drill. You know, they can get IT staff. They can get it for them. And in the past 5 to 10 years, we've gone to electronic medical records for EMS. We're actually ahead of most hospitals, or ahead of the hospital industry. And so the state, every single hospital EMS system in the state reports data to the state through a national interface called NEMSIS, the National EMS Information System. And actually, that's probably, I didn't even think of that. That might be worthwhile if you want to take a look at it at some point. It's called NEMSIS, NEMSIS. And they actually have drill down tools where you can look at EMS data from across the nation. I haven't done it in years, so I don't even know what their website looks like at this point. But it's the problem they're having is with feeders and who's giving data to them, and of course, as you guys know, bad data. That's a chronic problem. We have bad data. We go to many calls in Jamestown, New Jersey, just because the dispatchers typed the wrong J, and we end up having to go clean that up.
Okay.
So,
I was going to say, you shouldn't have that much bad data if you have a very narrow pipe, but I guess if that's the nature
right.
of it. Then.
So out of 90,000 calls, if the phone's ringing and things are going, and they type J, and it cycles through, the next thing you know, it's bad data. So at the end of the month, we'll run a report saying, how many calls do we respond to? And you're doing about 300 a day, so I can't think of what that comes out to in any given month, but you'll probably have 5 or 6 calls that'll show up somewhere randomly in some other city or some other state where they typed the wrong thing, and then you have to go back and clean it.
I heard fire also faced that a bit.
Yeah.
Well, I need to give you a standing.
Thank you.
Feel free to leave that there for us.
And let's click the button. There we go.
How much does Marvelous cost, by the way?
Marvelous? I don't know. The upfront for Marvelous was the most expensive. It was about $300,000 for us to get it started, and then we pay a yearly maintenance fee of about $20,000, $10,000 to $20,000.
You mentioned that there's 2 systems that you use for data. There's the Marvelous and.
Well, there's 3 analytical tools we use. Marvelous, which is VLIS,
Yep.
Mobile Area Routing Vehicle Location Information System. And the other one is called First Watch.
What was the third one?
And then we have data sources, so we utilize our CAD database, which is it's a company called TriTech.
TriTech?
Yeah,
They also
TRI.
make First Watch.
No, this is a separate company.
Okay.
This is just the data source. So our actual database is managed in our CAD, which is TriTech VisiCAD, VISICAD. And then the other data we use is called ZOLL, EPCR, so it's Electronic Patient Care Report. It's ZOLL, ZOLL, EPCR. And those are our 2 data sources, and then they're fed into the analytical tools, which is the Marvelous and the First Watch. Yeah.
Thank you very much, Director. This was awesome.
Absolutely, thank you. Enjoy your time. I know you guys were short on time, but